Hello, everyone. Thank you for joining us and welcome to VIA North America Metabolic Education Event live webinar. My name is Miriam Altena. I am a Territory Manager with VitaFlow North America. We're excited to bring you this live educational activity and introduce our final speaker. This webinar topic that will be shared with you today is the ketogenic diet for GLUT1 and PDH, practical implementation and considerations for long-term use. Please note this program is being recorded. You can access the PDFs of the handouts in the handout section in the control panel to your right. If you are tuning in via phone line, do not worry if you cannot access the slide deck. It will be emailed to you at a later time. Financial support for this presentation was provided by VitaFlow North America, a Nestle Health Science company. The views expressed herein are those of the presenter and do not necessarily represent Nestle's views. The material herein is accurate as of the date it was presented. It is for educational purposes only and is not intended as a substitute for medical advice. This educational program offers one continuing education credit for dietitians. You can download your certificate from the handout section in the control panel to your right, and it will be emailed to participants at a later time. Please note that questions will be addressed following the presentation. However, you are welcome to submit text questions into the questions pane at any time during the program. As with any CE program, questions relating to product will not be addressed. Feel free to contact your VitaFlow representative for further product information following the program. I have the pleasure of introducing our final speaker today, Wes Lohman. Wes Lohman is a registered dietitian in the specialty area of ketogenics and has been working as a pediatric dietitian within the Epilepsy Center at Ann and Robert H. Lurie Children's Hospital of Chicago for the last 5 years. Mr. Lohman's day-to-day tasks include the dietary management of one of the largest ketogenic diet programs in North America. He works alongside the Lurie Children's Keto team to manage the inpatient and outpatient needs of over 270 active ketogenic diet patients. He has a background in public health and childhood nutrition, as he has also worked as a health educator for the Women, Infants, and Children program. Mr. Lohman obtained his Bachelor of Science degree from the Appalachian State University in nutrition. He completed his internship at Lenoir-Rhyne University with a focus in childhood obesity prevention. Mr. Lohman has been a speaker at the first ever Families SCN 2A Foundation Conference and has presented research at the Global Symposium on Ketogenic Therapies. Welcome, Wes.
Thanks, Miriam, for such a nice introduction. Welcome, everyone. Thanks for joining us today. These are our learning objectives for today, so we're just going to have an overview of GLUT1 and PDH. We'll describe the practical implementation of a classic ketogenic diet. We'll explain some considerations for long-term use of the diet, and then we'll look at a few patient examples. So glucose transporter type 1 deficiency syndrome is a genetic disorder that impairs brain metabolism. So glucose isn't transported properly into the brain, which leaves it starving for energy. It's caused by a mutation in the SLC2A1 gene, which regulates glucose transport across the blood-brain barrier. For some signs and symptoms with GLUT1, you might see seizures, movement disorders, speech and language disorders, and developmental delays. And just a brief overview for PDH. So pyruvate dehydrogenase deficiency is a deficiency of the enzymes that convert pyruvate into acetyl-CoA. So too much pyruvate is made, which causes lactic acid buildup and a lack of energy to the central nervous system. The most common form is caused by mutations in the X-linked dominant E1 alpha gene. Symptoms similar to GLUT1 can include developmental delay, seizures, hypotonia, poor coordination, and difficulty walking. So just a little bit of an overview of the ketogenic diet. It's been around for about a century. We've seen a resurgence in the diet's use since the 1980s, following the advocacy efforts of the Charlie Foundation. The diet is high fat, low carbohydrate, and adequate protein, and it causes the body to use fat as its primary source of energy, thereby producing ketones. There are different versions of a ketogenic diet, including the classic ketogenic diet, which is measured in grams of fat to grams of protein and carbohydrates combined, the modified Atkins diet, the MCT oil diet, and the low glycemic index treatment. And so all these diets work in a similar fashion to provide an alternate source of fuel to the brain through the use of ketone bodies. This is a graphic representation of the different ratios of a classic ketogenic diet. And then on the left side, you have descriptions of the different versions of ketogenic diets that we just mentioned, with the reference to their relative ratios when compared to a classic ketogenic diet. So on the right-hand side, you can see that as you go up on the ratio of the diet, you'll notice that the amount of fat significantly increases and the amount of protein and carbohydrates decrease. So in the little vials that you see there, there's olive oil, and then in each cup, there's high-fat mayonnaise. So I always try to stress to families that as their child's starting on a ketogenic diet, the portions of their foods are going to be much smaller, but their calories and for growth and energy will be adequate. So if you notice, each plate on this graphic represents the same amount of calories, so you can see a big difference between the 1-to-1 versus the 4-to-1 ratio.
At this time, we'd like to offer our participants a nice opportunity for an interactive moment. You'll be seeing a poll question come up for you and in a moment, and you'll have some corresponding answers that you can select. The first question is asking, which diet are you most often prescribing for patients with GLUT1? And you have a couple options for answering. The first answer is the classic ketogenic diet. The second one is a modified Atkins diet, followed by low glycemic index treatment, MCT oil diet, or other dietary therapy. And we'll give folks a few moments to select the answer that best correlates to their most often practice. And we'll share the results of that poll momentarily. All right, it looks like the majority are utilizing classic ketogenic diet with 63%, followed by modified Atkins diet at 37%. You have the opportunity for another question, and this is relating to the use of the diet in your clinic, most often related to PDHD, or pyruvate dehydrogenase deficiency. And your options for answers are classic ketogenic diet, modified Atkins diet, low glycemic index treatment, or the MCT oil diet. And again, you can take a moment to select the answer that most correlates to your practice. And it appears that, again, classical ketogenic diet is the most often used diet in this situation with 69%, followed by modified Atkins diet at 28%. Lastly, MCT oil diet, 3%. Thank you for participating.
Yeah, thanks so much for participating. You know, this question actually came up at the most recent global symposium. People were asking or were advocating for use of modified versions of the diet for these children, and someone stood up and kind of argued the case that the classic ketogenic diet was the preferred diet of choice, and they were arguing that this was based on the fact that you want to provide that brain as much energy as you possibly can for growth and development. So, but we know that with using a modified version of the diet, you can still alter and modify the diet to create a higher level of ketosis and enhance the energy no matter what version of these diets that you're using. So thanks for participating. So just a little bit about the practical implementation of a classic ketogenic diet. So I'm just going to walk you through kind of our process at Lurie Children's. We meet with families initially for a 1-hour clinic visit. And that includes our nurse practitioner, our social worker, and the dietitian. we all sit in together with the family, so we're able to hear all of their questions and support them collectively at the same time. I really like having this 1 hour visit because we get to learn a lot about the family, and also it creates a sense of buy-in from the family, so their willingness to attend the initial diet clinic kind of validates their interest in moving forward with the diet. So after we meet in the clinic, the families go home and they chat about if the diet would work for them, and then they call us back and schedule a 4-day hospital admission. So between that time from the initial clinic visit to the families coming in to the hospital, their medications are changed over to lowest carbohydrate form. And this is something that you kind of want to keep in mind when you're starting someone on a ketogenic diet, is that their carbohydrate allowance is very low on this diet. And so sometimes the carbohydrates in their medications could completely negate the effects of the diet. So we generally recommend tablet forms of their medications. So they come in, and this is our advancement protocol, from a 1-to-1 ratio on the first day up to a 3-to-1 ratio on the third day. And then the patient's maintained for 24 hours on that 3-to-1 ratio. And that's actually our goal for sending the patients home on the 4th day, is a 3-to-1 ratio. We find that by staying at a 3-to-1 ratio, the patients tolerate the diet, start better, and for some patients, they don't really need a higher ratio of the diet to be effective. So a big part of that admission is diet education. And so we're doing lots of menu planning with the families. We're calculating everything according to the grams of fat to carbs and protein. We're utilizing Keto Diet Calculator, which we'll look at in just a second, to calculate their menus. We're talking about the social considerations of the diet, so things like school, birthdays, grandparents, holidays, any kind of social events that they might be taking part in, and what to expect and how to plan for those things. We're practicing weighing foods out on the gram scale. So we are fortunate enough at our hospital, we had a large donation of gram scales given to us. So we provide the family with a scale during the admission and then send them home with that to use at home, and they practice with it while they're there for those 4 days. We look at sick day guidelines and what to do on days when the child's not able to eat. Things like using half-strength Pedialyte and water for hydration, and then how to advance their diet slowly back to a full ketogenic diet. We look at adverse effects and what to watch out for signs and symptoms that the child might be experiencing excessive ketosis or low blood sugar without actually having to test the child's blood for those things. So what to do in those situations. And then we look at their micronutrient needs, and we're basically calculating their needs to meet 75 to 100% of the DRI for their age through a supplement. So for any of the kids who are eating by mouth, we're assuming that their foods aren't providing enough of their micronutrients. So in the case of someone that's taking a formula, then perhaps they wouldn't need a multivitamin, but generally most of our kids go home on a multivitamin and calcium with vitamin D supplement. And this is just a screenshot of the Keto Diet Calculator, which we use to calculate all of our meals and snack recipes for the families. You can see the 36% cream is heavy whipping cream. So in this example, this is a breakfast for a patient. This is a 246 calorie meal, and this is at a 3-to-1 ratio. So for this patient, they would drink 33 grams of cream, which is about an ounce. They would get 32 grams of unsweetened applesauce, 23 grams of a scrambled egg that they would weigh out on the scale raw and then cook to prepare it, and 12 grams of butter. And so every kid's a little bit different. So in this case, the family might melt the butter down and try to incorporate it into the applesauce, or for a lot of our kids, to the parents' surprise, they just love the taste of butter, so they can eat it straight. But we talk to families about ways for making the diet palatable and in a way that their child can enjoy it. So not only is the diet education very important for that 4-day admission, but the medical team's doing a lot of supervision during that time as well. They're looking at things like how well the patient's tolerating the diet, The nurses are testing their blood sugar every 6 hours. And this is only while they're starting the diet, so we don't have families test their blood glucose at home. But as they're going into ketosis, we like to monitor their blood glucose. And then we're checking their urine ketones with every void. And the nurses train our families on how to test their ketones at home. So the families go home and are testing their ketones in their urine twice a day. And then another consideration is for metabolic acidosis, which we know the ketogenic diet can cause. So we might check their labs at the start of the diet just to see where their blood CO2 level is. And if they're on any type of carbonic anhydrase inhibitor, then we might be pay more attention to this level. So these are some of the considerations for short-term use of the diet. Some of the potential side effects include constipation. If your patient becomes constipated, of course, you would want to optimize their fluid intake. Sometimes it's not enough. Many of our patients will still need a stool softener or a glycerin suppository. So these are some things to consider. Hyperlipidemia can be a side effect of the diet also. We usually find that once patients start the diet, their levels become elevated, and then within a year of them being on the diet, they should normalize typically and return to their pre-diet baseline or pretty close to that level. But if we get a level that's very high that we're not comfortable with, we might repeat it as a fasting level. And if it's still elevated, then we might try things like MCT oil. We might check their carnitine level to make sure that it's not deficient. We may recommend a fish oil supplement or decrease their saturated fat intake. And then again, for metabolic acidosis, this is something that we test in the clinic, which just tells us that the patient's body is too acidic. So in that case, we would offer them some sort of base. And our threshold for treating CO2 level is if it's below 18. So for those patients, we might prescribe potassium citrate or sodium bicarbonate. Kidney stones are a possibility, but they're pretty rare, only occurring in about 3 to 7% of cases. And I feel like we see kidney stones even less than that. Typically, if someone is experiencing metabolic acidosis and it goes untreated, then they're in a much greater risk for kidney stones. So that's why we monitor those levels very closely and treat them if necessary. Carnitine deficiency may also be a result of the diet. So the body is needing carnitine to break down such high quantities of fat, and sometimes the diet is not providing enough carnitine by itself. So a carnitine supplement is not uncommon as well. There are some mixed data related to stunted growth with the ketogenic diet. In general, someone who's on the diet for greater than 6 months may see some linear growth stunting. But in these cases, we feel like, and families typically agree, that the use of the diet outweighs the risk of not using the diet. More considerations. So for routine follow-up for these kids, it's generally recommended to see them each 1 month after starting the diet, and then every 3 to 6 months after that. At each clinic visit, we'll test the patient's blood work for their complete blood count, their electrolytes, their liver and kidney function tests. We'll check their lipid profile, their carnitine profile. If they haven't gotten a vitamin D level checked recently, we'll test that, and then we'll check their blood ketone levels. So at home, the families are testing their urine ketones, but when we see them in clinic, then we'll get a beta hydroxybutyrate level, just as a more accurate indicator of their ketosis. And then, of course, if we're seeing infants on the diet or a patient that's already malnourished, then we might schedule their follow-up more frequently. So kind of like we mentioned already, some supplements to consider. Generally, a multivitamin and a calcium with vitamin D is recommended. Sometimes if you suspect a deficiency, you might consider other micronutrients, things like zinc and selenium, magnesium, salt, and iron. And then again, any citrates for acidosis or stool softeners for constipation. So these are some considerations for long-term use of the ketogenic diet. Basically, this was from the consensus statement. The long-term vascular outcomes of this high-fat diet are not known. However, we feel like the quality of life is vastly improved, again, on a ketogenic diet versus a regular diet for these patients. Cardiac abnormalities have been reported, but the mechanism is not fully understood. So routine monitoring is not generally recommended unless there's some kind of history of heart disease for the patient. And overall, we feel like the long-term serious adverse effects is pretty low. I know at Lurie Children's, we've treated many patients who've been on the diet for greater than 10 years without seeing any significant side effects that would warrant us stopping the diet. I think more pertinently, a big long-term consideration for these patients is diet burnout. So, and as many of you may know, sometimes it's the patient who's burnt out on the diet and sometimes it's the caregiver. So we just always try to keep that in mind. Families sometimes get tired of restricting their child's diet or having to avoid certain foods or giving them more repetitive types of meals or weighing their meals out on a gram scale every day can become kind of tiresome. So generally, as patients grow older and they're able to make more of their own food choices, or as the families are experiencing some of this diet burnout, sometimes we have to transition to a less restrictive version, such as a modified Atkins diet, to help them to stay on the diet and still stay in ketosis while giving them a little bit more freedom in their diets. So we're going to go into a few patient examples. Our first patient is an 11-year-old boy. He was diagnosed at 6 years of age, and he was sent to the diet clinic right away. So this is a PDH patient. So at the initial diet clinic visit, the mom reported to us that the patient began having events just before his 3rd birthday, where he would become ataxic, have slurred speech, and difficulty swallowing. She told us that basically anything that required coordination, he was unable to do. And at its worst, he wasn't even able to walk. So she was telling us that this had continued since the events first started 3 years ago. The episodes would occur a few times per year, and they were always in association with a fever or illness. And his symptoms would usually last for about 3 to 7 days, and he had been hospitalized multiple times for these episodes. So we met with this family. The patient presented with what seemed like good family and social support for the diet. The grandmother was present at the clinic visit, and she's the one who would prepare his meals and take care of him when the mom was at work. So it seemed like they had a good family support structure. He came to us with a list of foods that he wanted to ask if he could still have on his new diet. And so it was just a good example of how the family had kind of mentally prepared him for that first diet clinic and then also for considering going on the diet in the future. So we were able to set him at ease by telling him that most of these foods he could still have. And we were just pleased that the family had researched the diet and came prepared for the diet visit. So when he told us about the foods that he would typically eat, they included things like pancakes, cereal, scrambled eggs, bacon, hot dogs, fruit cups, graham crackers, fruit slices, cheese, the list goes on. So mostly, pretty typical kid stuff, but it looked like he had a good variety of intake of different foods that we felt like the diet would be a good fit for him. He was at a healthy BMI, and there weren't any concerns for malnutrition for him to start. So they started the diet right away. They came back a week and a half later to the hospital to start his diet. He went into ketosis pretty smoothly with no real issues tolerating the diet, and his urine ketones were large before he went home. So he went home on the 4th day at a 3-to-1 ratio. The diet education went really well the week of the admission, and it seemed like everything was going pretty smoothly. So he went home on a 3-to-1 ratio, and he maintained that ratio for about a year. The family was very pleased. They were reporting an improvement in his weakness. His motor skills had improved. His attention was better. He wasn't 100% better, but they felt like this was such an improvement from where he was. They were very pleased with the diet. His growth looked good. His BMI was always around the 50th percentile. His urine ketones were consistently moderate to large, which is what we would want. And around that 12-month period is when the mom started to ask if we could maybe decrease the ratio slightly to see if he could have a little bit more freedom and flexibility in his diet while still seeing the same benefits. So we agreed to a very small reduction in his ratio to a 2.75 to 1. He tolerated that well, still seemed to see similar ketone production and the same kind of results as the 3 to 1. And over time, the mother would continue to ask if they could maybe further reduce the ratio. And I think in her mind, she always had hopes of eventually coming off of the diet. I think she felt bad about restricting his diet and him having to be so strict with everything. And so eventually we reduced his diet down to a 2.25 to 1 ratio, which is not too low. But the mother did come back and report to us in the clinic that he seems less focused and less coordinated since the start of that next school year. So, but she still she wasn't in any hurry to increase his ratio back up. She wanted to keep trying at this lower ratio, and she did express that eventually she would like to wean the diet completely. Eventually, after some time and multiple conversations with the patient's epileptologist, they agreed to a trial of him going off of the diet. And unfortunately, it wasn't too long after we weaned the diet that he was readmitted to the hospital for these events of ataxia and dysarthria. So, and it was actually the first time that he had been readmitted since originally starting the diet. So we had kind of been whispering the modified version of the diet to the mom before this. And so during that hospital admission, we did start him back on a modified Atkins diet, and that's what he went home on. So the family continued this diet for about a year. And at that time, the mom called to request going back on a classic ketogenic diet. It seemed like for this patient, a modified version of the diet just wasn't strong enough for him to really see improvements. And then his ketones even reflected that they were traced to negative while he was on a modified diet. The mother especially noticed it when he was returning back to school. She would see that his school performance was not where it had been on a classic ketogenic diet. So we started him back at a 2 to 1 ratio of the diet from home because he was already in ketosis and didn't need to be readmitted to restart a classic diet. And then we followed up in 2 months in the diet clinic. And the mother was at this point requesting that we increase the ratio. His ketones were small at the 2 to 1 ratio, and constipation had become an issue for him. So they were using stool softeners to help him to stay regular. His length for age still looked great, around the 30th to 40th percentile, and his BMI was still around the 50th percent. So we increased the ratio ever slightly to 2.25 to 1. And so the last time that we saw this guy was over the summer. He's still at a 2.25 to 1 ratio, and he's been there for about a year and a half. Still having some constipation, but he follows the diet very strictly, which is one thing that's really, really cool about this guy is he always follows the diet very strictly. He would always advocate for himself and refuse foods that he wasn't supposed to have that were offered to him by other family members or friends. He's still having some episodes of weakness, but the mom feels like this is really the optimal spot for him and for the family, where he has enough flexibility in his diet to still have some of the foods that he really enjoys while maintaining a level of ketosis that's benefiting him. So throughout the course, looking back, there were multiple summers where the family would try to be a little bit more lenient with his diet. And I think for his time at home and throughout the summer, that was okay. But then when school started, it became more evident that he needed a stronger version of the diet. So just a couple lessons that we learned from this guy is that sometimes it's easy for families to forget how bad things were. And I think in this case, the family got started on a ketogenic diet. He was doing much better, and they kind of got used to how well he was doing and forgot that it was the diet that was really the big change for him. And so kept advocating for going back or off of the diet, which in his case was not very helpful. And then another lesson that we learned from this family is that, as always, that diet therapy requires a personalized approach. And while a modified Atkins diet may be sufficient for many patients, every kid's a little bit different. And so for him, it just wasn't enough to be effective. So our next patient is a 7-year-old girl. She with GLUT1. Her seizure onset was at 1.5 years of age. She wasn't diagnosed with epilepsy until 5 years of age, and her GLUT1 diagnosis didn't come until she was 6, after whole exome sequencing was done. So at the initial diet clinic, her seizures were occurring multiple times a day. She would have staring spells with a head nod that would usually last for just a few seconds. The patient presented in clinic with mom and dad. Her nutrition concerns included a history of underweight, and the parents said that she had always been a little bit underweight. She ate really well. She ate 3 meals a day. She ate snacks between meals. She wasn't a picky eater, but yet her weight was still on the lower side. The parents and the family seemed they seemed very prepared and capable of doing the diet, but on their side, they were very intimidated by the diet change. And so you could tell that they were kind of afraid to commit. And I think they were just afraid that they were going to mess something up. So one thing that, as I mentioned, I like about our clinic is our nurse practitioner and our social worker and the dietitian are all sitting in together. So we were able to kind of set their minds at ease and reassure them that they would be able to do the diet well. Before the diet started, she was eating things like eggs, oatmeal, pancakes, berries, cheese sticks, pepperoni sticks, olives, cereal bars, avocados, steak, tortillas, pasta, again, some regular kid foods. And the family had already started incorporating some more keto-friendly foods like the olives and pepperoni and cheese sticks. So they were already on the right track. So they went home, talked about it, and they came back a month later to the hospital to start the diet. So again, at the diet initiation, it was kind of the same picture as from the initial diet clinic. The mom had a lot of concerns, and you could tell that she was overwhelmed and very intimidated at our very first meeting when they came into the hospital to start. So I put all the education for that day aside and just listened and tried to support and offer her as much reassurance as possible that they were going to do a great job with the diet. So we met again that following day, and we were able to kind of jump right into the education on that second day. The patient was in a moderate malnutrition category based on her BMI starting the diet. And then she was only eating about 50 to 75% of her meals during the admission. The diet education was going very well, and we had created a lot of menus together with the mom that I felt like they were prepared to do the diet at home. But unfortunately, around the second or third day, her acidosis became too strong, and she was having some nausea and vomiting going into the third day of the diet start. So rather than increasing further to a 3-to-1 ratio, we just maintained her ratio at 2-to-1, and then we started potassium citrate to kind of manage her acidosis. So she was able to go home on the fourth day at the 2-to-1 ratio, and it was kind of neat. So the family noticed seizures on that very last day before going home, and then they haven't seen any since. So we met back in 1 month in the clinic, and the family was very pleased at this 1 month follow-up. She was still at a 2-to-1 ratio. She was eating a lot better, and her intake improved as soon as she got home, which is something that we often see, and I will usually tell families, like when they're in the hospital, they're outside of their comfort zone and the meals look different. So sometimes some of that poor intake can be related to those things. But she was eating things at home on her ketogenic diet like chili and eggs and hot dogs. The parents had bought a shaved ice machine, and so they were actually freezing and shaving Powerade Zero for her, which we all thought was very cool. And the parents were very excited because it replaced the ice cream snacks that they used to have as a family together. Her ketones were large, and she was struggling a bit with the heavy cream, but the mom was adamant about maintaining that as part of her diet to keep working with her on taking the cream. So overall, everything was going really well. She was actually eating about 4 meals and 4 snacks a day, so her intake really had increased. She had regained the weight that she had lost from the diet initiation, but she hadn't surpassed that. Her BMI was still in a moderate malnutrition category, but her weight was moving in the right direction. So we decided not to make any big changes to her calories at that point. I told the family if they wanted to double her snacks, they could do that, and we would just monitor her growth and weight. The parents were thrilled with the diet, and they were really advocating that we stay at a 2-to-1 ratio rather than increasing to a higher ratio of the diet. And I was in agreement. I thought it would be nice to see her gain a little bit more weight, and since she was making good ketones and seeing lots of improvement, we felt like the diet at a 2-to-1 ratio was effective for her. So we met back in clinic 3 months later, and we told the family to call us sooner if her weight didn't improve in those 3 months. So the mom emailed me about a month later, and she said, you know what, she's eating great. I think she could eat even more. So we increased her meal calories by 10%. And then we met back in clinic 2 months after that. Still not seeing any seizures, still at a 2-to-1 ratio, still eating 4 meals and 4 snacks a day. The family was thrilled with the diet. The dad reported that this was the first time that the patient had been able to go across the monkey bars on the playground all by herself. They noticed that she was doing better in school. She was more attentive, more alert, and you could tell that the patient felt better about her performance in school as well. Her ketones were still large, and she had gone from moderate to mild malnutrition, so that was a good sign also. The family told us that they were practically experts in preparing the diet at that time, and they were able to go to their favorite restaurants and order things from the menu and weigh them out on the gram scale to keep them ketogenic. So we made a small increase in her calories, and we saw her again 5 months later. So when we saw them back in clinic, her ketones were still large. She was eating a little bit less, but still significant, 3 to 4 meals a day and 2 to 3 snacks per day. Still not seeing any seizures, and still seeing those cognitive and physical improvements. So that was the last time that we saw them in clinic. They were very comfortable maintaining the diet, and she's kind of going strong at a 2-to-1 ratio. So some of the lessons that we learned from this family is one was that the perceived barriers may not always be actual barriers. So in this case, the family was very overwhelmed and intimidated by the diet, but we could tell by the report that they were giving us initially that they should have no problem doing the diet. So over time, they just had to jump in and start doing the diet, and they've become very comfortable with it over time. And then another lesson that we learned from them is that the goal ratio is not always the goal. So our goal for advancement of the diet is to generally start someone at a 3-to-1 ratio. And then for this girl, we thought that with her going home on a 2-to-1 ratio, when we met back in clinic a month later, that we would inevitably increase the diet ratio for her to make good ketones and for the diet to be effective. But for her, she was really seemed to be optimal at a 2-to-1 ratio. So our next patient is an 8-year-old girl with a seizure onset of 9 months of age, and she was born and lived in India for the first 5 years of her life. Her seizures were controlled with Onfi, but she was found to have GLUT1 in August of 2017, so just last summer, at 7 years of age. So she met with the diet team right away. At the initial clinic visit, she presented with her mom, her aunt, and 2 uncles. And she lives at home with mom, dad, both sets of grandparents, 2 uncles, 2 aunts, and a 10-year-old brother. So it was a full house, and the mom was proud to tell us that she prepares all the meals for the entire family. They're a vegetarian family, but they were okay with incorporating things like eggs, cheese, and yogurt into the diet for protein, because I had explained to them that while a lot of her protein was coming from things like dry beans and legumes, that while on a ketogenic diet, the portion of those foods would be very limited due to the carbohydrate and starch in those foods. So she was eating things like bagels, cream cheese, lots of Indian curries with vegetables and lentils, roti wraps, peanut butter and jelly sandwiches, grilled cheese, chips, pizza, American food, and Mexican food. The family basically told us that she's not a picky eater, she'll eat anything, and she loves spicy foods and cheese. So some of the nutrition concerns for her included constipation prior to starting the diet, and she was also a bit underweight. She was in the mild malnutrition range. And so the family went home and discussed the diet, and we started her diet a week and a half later. During the initiation, the mother was present at the bedside every day for diet education. She knew in advance that the foods that the patient would be eating during the initiation would look different from the foods that she would be getting at home, that all the foods would be provided by our kitchen at the hospital. So we were advancing each day according to our protocol, and we just couldn't get the patient to eat more than about 50% of her meals. So she too developed acidosis and had to maintain her diet at a 2-to-1 ratio and start potassium citrate. So this was around the 2nd or 3rd day that we decided to keep her at a 2-to-1 ratio, and the mother had let me know that she really felt like the primary issue with her not eating was that the foods were just very bland. And so I went to the kitchen and I got all the spices that I could find from the kitchen, and I took them up to the room and left them with the mom and told her basically to season the foods as she sees fit, and if she needed to reheat things in the microwave, that was okay. And so once we made that change, she started to eat a lot better. We still maintained a 2-to-1 ratio for her to go home. And so we met back in the clinic a month later, and the family reported similarly that her intake improved right away, and she was eating her usual 3 meals and 2 snacks a day. Her constipation had actually gotten worse, so they were treating this with a stool softener, and the mother reported to us that the patient was more alert. Her ketones were ranging from trace to moderate, but overall the family was pleased with the results of the diet. And then mom brought a long list of ingredients and food labels of things that she wanted to incorporate into her diet going forward. Her weight status had stayed about the same. She was still in the mild malnutrition category. So we incorporated the new foods and we increased calories to try to get some weight gain. And when we reviewed the labs, we saw that her carnitine level was low, and so she was put on a carnitine supplement. We also noticed that her blood ketones were low, and so we increased to a 2.5-to-1 ratio. At the next clinic visit, the family reported that occasionally her ketones were negative, and they also noticed that her weight had decreased from the previous visit, despite the fact that we had increased her calories. And so right away as a team, we kind of suspected, because we've seen this many times before, that the family just wasn't giving, or the patient wasn't taking all of the recommended fats. And so we talked to the family about ways to incorporate fats, or to think of the oil in the recipe as a medicine shot that the patient could take at the start of the meal, or to use flavored fats through like fat bomb recipes that they could incorporate into our diet. So we gave them some tools to work with. We didn't make any calorie changes at that point because we felt like the calories from the prescribed diet would be adequate for some weight gain. So we just encouraged them to incorporate all the fats into her meals. We met back a couple months later, and the mother emailed me a couple months later and was reporting seeing some negative ketones still. And so we increased her ratio to a 3-to-1. And then 2 months later, we saw them in the diet clinic again. and her focus had improved, and her gait seemed to be improving. Her ketones were trace, which is not where we would expect someone to be at this ratio. Her BMI was relatively unchanged, and so we increased her calories and increased her protein at this time. The mom brought some more food labels for us to incorporate, and so we did that. So that's kind of where they've been. We've been trying to work on ways for them to be sure that she's getting all of her fats in her diet. She was seen by her epileptologist most recently, and the epileptologist got blood work and found that her blood ketones were even lower than the previous measure, so it's still a work in progress. I called the mom and talked to her about different ways to work with the fats. She explained that she felt like the oil was a real barrier for the patient, and so we converted all of her recipes to using butter and ghee instead of oil. And then we gave the mom some recipes for some meals on the go that she had asked for, like Taco Bell and Chipotle. So some lessons that we've learned with this family is that sometimes it takes time for families to trust a diet. In this case, I feel like the family trusted our medical opinion, but they weren't convinced, I guess, that the diet itself would work, and so they were still restricting some of the fats and not fully grasping the notion of how effective the diet could be. And then another lesson that this family kind of showed me, and something that I've seen in other families too, is that sometimes you have to give families permission to contact you. And sometimes it's cultural that certain families will feel like it's only appropriate to reach out or to raise their concerns to you when they're physically in the clinic. But for something as comprehensive as a ketogenic diet, we really need families to be in contact with us in between those visits to let us know if their child's not gaining weight or if they're not making ketones appropriately. Just letting families know that we're there to support them and that they can contact us anytime for help. And then just overall, a few diet lessons. The first one being the new normal effect of the diet therapy. I feel like sometimes families get used to the new baseline for their child and an improved child, and they're looking so much better than they were before the diet. And so while as a team we know that they might be able to benefit from some further adjustments in their diet, the family is very content with where they are. And so just working with the families and encouraging them when you feel it's appropriate to further increase their diet or make adjustments that might give them even more benefit than they're already seeing. And then also, as always, making cultural accommodations. Food's one of the most basic and powerful means of providing love to your child, and so we always try to make every possible accommodation to support the family's adherence and even their psychological acceptance of the diet therapy. So we want their ketogenic diet to look as similar to their usual diet as possible, and we want it to look as similar as possible to the rest of the families as well. And then just always considering family and friends, considering the entire social life of the patient, including their grandparents, their friends, any kind of social events that they might be attending. We know that these will dictate the types of foods that they're offered, and so we try to ask those questions about the family, extended family and friends, even when the families aren't offering up that information right away to us. And then I guess the biggest kind of lesson for me is just how valuable that comprehensive approach is. We're very fortunate. I feel like all the members of our team are very well versed in the diet, and so if a family calls in with questions, everyone's able to kind of address and support them with whatever their questions or concerns might be. So whether it's our nurses or the physicians, our APNs, our social worker, even our education specialists, we've trained everyone in the diet, and so they're able to answer a lot of those questions and provide support to the families. And then we're able to provide support to each other that way also. So that's it for today. Thank you all for listening, and then we'll have time for just a few questions. But if there's anything that we don't get to today, you can email me at the email address there.
Thank you, Wes, for an excellent presentation. I'd like to remind our participants that you can submit your questions using the questions pane in the right side control panel. And we'll allow for a few moments for people to submit their questions. So it looks like we have a question here. Participant is asking if there are any recommendations to help families navigate the ketogenic diet with regards to schools.
Yeah, that's a great question, and one that we get all the time. So we do have a letter that we'll provide families, which basically states that to the school that they should only be providing foods that have been prepared or approved by the family, and that's usually very helpful. Sometimes our education specialists can get involved too and meet with the school to provide some guidance or further explanation of the diet. And then in general, we would say a lot of families will ask us, you know, is it possible that should we have the school prepare these meals for them? Isn't that their job? And we basically never have the schools prepare any of the meals for the child. We're always encouraging families to send their pre-made keto meals with them to school.
And it looks like we have another question from Marie asking if there's a concern about the lifelong commitment for those patients. I assume that is commitment to the ketogenic diet.
Yeah, absolutely. And I think like in the case of our first guy, maybe a stronger version of the diet might be best for him. But if that's not a reality for the family, then we just try to work with the family to come up with any way possible that we can maintain the diet, and even if it's a lower, less strict version of the diet, so that they're still seeing some benefits from it. So just being very creative with their diets, using a modified version if we need to. And these kids will grow older, and eventually they're going to be making more and more of these dietary decisions on their own. So, you know, maybe a modified or a carb counting diet's more appropriate for them, and maybe incorporating things like MCT oil or coconut oil to give them a kind of a boost of ketones is something that will help them to stick with it for the long run.
The following question comes from Stacy asking about dosing of potassium citrate or sodium bicarbonate for treating acidosis in these patients.
That's a great question. I'm pretty fortunate because our APNs are typically in charge of these types of things, and so it's something that I don't even have to fortunately address very often, but I think we're treating with we started about 2 milliequivalents of bicarb per kilo. So, and it just depends on which supplement that you're using and as to how much bicarbonate it contains. But that's usually where we're starting.
Another question is also from Stacy asking about the frequency of checking liver and kidney levels every 3 months.
So we generally will obtain these levels whenever we see the patient in clinic. So as they're starting the diet and within that first year, it may be every 3 months that we might see them in clinic. But then as they're on the diet for longer, then we may space their appointments out to twice a year, or if they're seeing their epileptologist, then maybe we're staggering it so that we're only seeing the patient once a year. So those tests become less frequent also.
You also mentioned salt supplementation earlier. This is another question asking about what product or dose of salt do you use as default?
So salt especially becomes necessary if we're seeing a patient who needs a specialized formula and they're not getting enough sodium in their diet, or the components of their formula basically providing no sodium, then we might use something like just a basic salt, or sometimes a light salt to give them some potassium and sodium. And I would usually give them somewhere around 30 to 50% of their DRIs.
A following question is, does timing matter for checking urine ketones at home twice per day?
I would say no. I think so. It's very common for patients' ketones to be lower in the morning and sometimes higher in the evenings. And so we'll just tell families to check sometime in the AM and then sometime in the PM, so that, I mean, the goal really is just to make sure that they're in some level of positive ketosis. Sometimes we'll see trends with kids where their ketones are usually moderate to large range, and then if we notice a sudden dip, like that's very uncharacteristic for that particular patient, and we notice that they're doing worse, then we might wonder if they got something in their diet that they weren't supposed to have. But yeah, the timing is pretty loose. I would say just generally sometime in the morning and sometime in the evening, and not to worry too much if you see some fluctuation. It's pretty natural.
Looks like we have another question asking about an idea about any of the long-term side effects. Again, assuming this is related to the diet.
Yeah, so I think most of those things that we know about, we're really monitoring for. We haven't really seen any long-term cardiac issues or any kind of problems that you would typically associate with a high-fat diet. Our thought is that maybe using a high-fat diet in the absence of high carbohydrates, it doesn't have the same effect as if you were eating a high-fat diet alongside high carbs in your diet. So we're doing those routine labs when we see the patients, but we haven't had any issues where anything unexpected has come up in the long term for the kids who've been on the diet for greater than 10 years.
All right, well, thank you again to Wes and to our audience today for your participation. On behalf of VIA VitaFlow in association with you, we hope that you found this information valuable to your practice and you enjoy the rest of your day. Thank you.